Mary Katherine Howell is an advanced fellow at the Mental Illness Research, Education, and Clinical Center, or MIREC, at the VA Maryland Healthcare System. And her clinical and research specializations are in treatment for PTSD, insomnia, and serious mental illness. It's extremely exciting to have her talking here today because I've got to know Mary Katherine over the last several years. She's in our fellowship program, and myself and Alicia and others mentor her. And it's just been great. It's been great getting to know her and see her ideas blossom from ideas to fundable research ideas. The two things aren't always aligned. So it's been a great process. Dr. Howell's research focuses on developing, evaluating, and disseminating approaches to treating stress and trauma for veterans with serious mental illness, as well as testing and incorporating culturally responsive methods to improve functional outcomes. And she received her PhD in clinical psychology from Howard University. So I'm thrilled to hear her Ignite talk, which you see here is titled Assessing Cultural Identity During Research and Clinical Care. Hand it off to you, Mary Katherine.
Thanks, Melanie. I've given this talk in different forms quite a bit, and often I am speaking to clinicians, but I'm going to try to de-emphasize, some of the, interesting clinical implications. I think I heard that some of you are also licensed clinicians and practicing, but I really will try to keep the focus more today kind of on research implications. All right, now this is being very slow to respond. There we go. So just an overview of kind of how we'll kind of break things down. There's a really helpful framework for understanding how we obtain greater cultural competence. Even though that's not my favorite term anymore, cultural competence for lots of reasons I could go into, this idea of we need awareness. First, we develop knowledge, and then we also need practical skills to actually enhance our ability to engage in culturally responsive research, assessment, treatment. So that's kind of how I structure my talk today too. Just to lay a foundation, so many of you are engaged in health disparities work, so I don't need to talk about this likely extensively, but just to lay a foundation that we know that cultural identity impacts our vulnerability to, experience of, and recovery from mental illness, and that health disparities are observed in almost every cultural identity domain, and we could go on and on and on. But the other thing that I want to make really clear, and many of you, again, who are doing this work in health areas related to health disparities know this likely even more deeply than I do, that it is so important when we are analyzing results for the purposes of health disparities research, when we are writing up our rationale for why we think these health disparities occur. It's very important to resist the logical fallacy that health disparity kind of talk and research can really suck us into, which is the idea that observed disparities are somehow essential to someone's identity. It's really important that we're always emphasizing the historical context, the power and kind of oppressive power of various systems to create these disparities, that they're not essential to who these individuals are. And this is a quote from actually one of my professors at Howard, a great article that she and her colleague wrote about even the way this specific example of how the logical fallacy of race and racism kind of were worked out, and that there was a lot of scientific knowledge that was proliferated around the 18th, 19th centuries, attributing fixed characteristics to people of certain races. And there are just infinite kind of empirical issues with their work at that time. But the way we talk about, for example, just using the example of race, it's very common that you'll find that people, even in doing this work, will refer to, race was a covariate, and so we found that the Black folks were like this and the white folks were like this, without also naming the historic power dynamics that have created some of these disparities that we see. And just a couple more notes on power and the importance of acknowledging that and using this language when we talk about our research and when we write up our research, is just to talk about privilege and the styles we can have of relating to our power, even as researchers. We could be sharing power, wielding power, building power in groups of people. When we don't consistently, kind of returning to the focus of my talk, evaluate cultural identity in research or clinical work, we're at risk of being power blind, saying, I don't really see this, I know that there are differences, but not really naming power can result in that, or being power neutral. Like, we see that there are these sort of observed differences, and they do seem to be related to systems of oppression that create power differentials. Or we can outright be power hoarding, where we see a dynamic, and maybe this is not even in our research, but with our coworkers. I see a dynamic of power hoarding, but I'm not interested in sharing the power that I have or making a given sacrifice. The status quo is working well for me. So I just wanted to put some of these concepts out here because they're just so important before we begin conversations about identity and the associated relative privilege and power, or experiences of oppression that often different areas of identity and where we identify in a given domain result in for us. Also wanted to lay a groundwork of the importance of taking a stance of cultural humility when we approach our research and our clinical work. And it's essentially just an other-oriented focus. And we know that having cultural humility and having the folks we work with, whether it's clients or participants, experience our culturally humble stance has big impacts on their engagement with us and their interest in engaging long-term. That cultural humility scale I'll come back to, because I'll have a list of measures for you all to kind of consider for your own research projects as well as clinical work going forward. I'd love for people to put in the chat, not that we'll have discussion about this, we can maybe discuss this piece after my talk, but if people want to start thinking about putting in the chat, how are you currently assessing cultural identity factors in your research and or during clinical care? What does that look like? If it's informal or via just a study-specific demographic form, what are some of those cultural identity factors that you are consistently querying for? And if you're querying for it more formally, what validated measures or any measures that are you using? So if people can start putting that in the chat, that would be, I think, really of interest for our conversation later. And I know that my colleague who's presenting after me today is probably going to talk about this quite a bit more and has, certainly a much more sophisticated knowledge of this concept. But just to, again, lay a foundation for what I'm about to present as far as my brief approach is the concept of intersectionality, which is that we know that because oppressive systems work in such a way that they don't act on only one domain of who we are. We also know that what this creates is really interlocking systems, not only of oppression, but then of how our identity functions and maybe what aspects of our identity become more or less salient in what settings. Maybe a research setting, or in your study, how a participant's relating to you could be really fundamentally different from the aspects of our identity that are most important to them, that they're most wanting to share with you or comfortable sharing with you about, could be really different based on context. And this is all related to this concept of intersectionality, that people are more than just one dimension, and that this dimensionality really changes based on context. This is an image that I use in this brief cultural identity assessment that I'm going to introduce you to, but this right here displays this concept of the range of cultural identity domains that we could be talking with our participants about and even our coworkers about. And it's just an image that I do use the actual image when I do this assessment to quickly communicate to participants or to clients and patients the range of things that they could share with me. Instead of me having to read out a list to them, I find this visual aid to be really helpful. And so that way I don't have to use words like intersectionality or teach these sort of academic terms in a quick research or clinical context. I did say that I would share beyond the brief approach that I'm going to tell you a little bit about today, that I just share a quick list of some measures of interest, some of which you may be aware about, some not. That cultural humility scale, one more note I'll give to you about that is just that you can actually administer it to your participants and patients to give you feedback about their perception of how culturally humble that you were in the interaction, but you can also fill it out or have your RAs fill it out about their own reflection about their level of cultural humility in that interaction with a participant or with a patient. The gold standard cultural identity kind of assessment that is out there is called the Cultural Formulation Interview for DSM-5. So it's been highly researched, studied all over the world. It's a very rich measure, and it's a gold standard measure. It is a little bit lengthy, so it's about 20 minutes in length. And my cultural identity assessment, this brief version, is based off of a few questions from that I developed for some of the unique needs in my VA context. But one of the CFI developers, Roberto Luis Fernandez, is a mentor of mine for my Career Development Award proposed project. So that just to give you a sense that this is one of the gold standard measures. It is a bit longer to administer depending on your needs. And I found it to be a bit long for mine, but it's an excellent, robust measure, and I really encourage you to take a look. These others are self-reports that are a bit more about stressful experiences related to identity. And there are many others, that, the MIBI, things like that, that are frequently used measures. But some of these here are a bit more flexible as far as what type of cultural identity domain and stress related to that, that you might want to query about. So if you want to query beyond just stress related to race and racism, like the unrest, the TSDS, for example, you can see here is one that's flexible. So please be putting these things in the chat too. If you know about measures that aren't listed here, it would be great to see those in the chat and discuss after. Just a little bit more about the CFI, because this is what my brief approach is based on. They have an outline here. You can see it assesses lots of different areas. How does someone view their mental health issue, their problem that they're seeking help for? Then what are their perceptions about what caused this problem, and what sort of support have they sought for it? What's affecting their past help seeking, current help seeking? And like I said, it's about 20 minutes to administer. And that's even once you get trained and you can become quite fast at it. As you can see, 16 questions. So 20 minutes would be pretty fast for 16 questions. And these are those 8 through 10 questions that I focused my brief approach on. And you'll see how those are quite connected to the questions and the provider discussion guide, really, that I've created and that I've used a lot clinically. I've used it in my professional relationships and small teams I'm a part of with coworkers. And I'm now beginning to look at it in a pilot study that I'm running right now that's been funded by the MIRAC. Some of the clinical observations I've really already shared with you, and I won't go too deep into these, just to say that there are a lot of time pressures on VA providers, and that results in a lot of inconsistency about how or if people are assessing cultural identity in their very first patient interaction. And so with all of those time and resource pressures, it caused me to want to think about what could be a little bit more systematic way of gathering information, but that's also flexible and quite person-centered. Like I said, this is currently being evaluated with the MIRAC pilot, and I'd love to know, since they're hoping, I can hear Jody and Melanie and others saying that the hope of this, and Aaron, the think tank, is to maybe spur ideas for opportunities for collaboration. So if you're interested after hearing this talk and maybe incorporating this brief approach into what you're doing, I'd love to talk. All right, so I'll walk you through essentially this brief guide. This conversation could be as brief as 5 minutes. It can certainly be longer if you have the time and if the participant or patient that you're working with wants to have more space to talk. But we start off with cultural humility and say something like, as we get ready to work together today, something we often find helpful to think about is how our identities might influence and be present in our work together. And then sort of coming in with the concept of intersectionality, even though, again, we're not teaching them these terms. We all have different aspects of our identity. Some are seen and some are unseen that make us who we are. And some of these aspects might show up or become more important in certain settings. I show them this wheel, and folks that I've trained to do this will show this wheel. And we kind of introduce them and just orient them a little bit to how things are organized. You can certainly read through the things we can share with them, but the outer ring tends to be Some things we might be able to control and others we can't, because they're influenced by parents, our communities, and different systems of power. But some of the things in the outer ring might not be as easily observable or apparent. So all the more, can be nice to have a space to share. And then the inner ring, we just orient them to that these are facets of identity that we really don't control. And as a result, we might take for granted that they, of course, affect our experiences. So they might not be as top of mind. We might not be as used to talking about them quite explicitly with a provider. And then just open it up with a simple question. How do you define yourself on some of these aspects of identity? Typically, people upon first meeting will only share maybe one or two, maybe three. And then, if it's helpful to have some more specific questions, they don't quite latch on to that broad question. You can say something like, well, when you show up to the VA or when you show up to shock trauma, which of these things are the most important to you or feel the most relevant? Which of these things do you think might be the most important for me to get to know about you as we start our work together or do our work together today? And then however long or short that conversation is, depending on the needs of the situation and the person that's in front of you, you would just put a pin in the conversation. And say, the safety and trust in our relationship, as hopefully that grows, it might change what we decide to bring up together. This would be if you're going to meet someone multiple times and want to invite these conversations to continue with the person that you're working with. And also to acknowledge, hey, some of the things you may have reflected on that are in this wheel, you may have reflected on them a lot, or it may be pretty new to you to talk about these things. There are optional modules where you can certainly query stressful experiences they've had related to identity, gender-based harassment, race-based stress and trauma, and other domains. So this is an optional additional module for that, as well as strengths related to identity. And these are the other questions that are paralleled in the CFI too. Are there aspects of your identity that are a particular source of strength or pride for you, or that have helped you to cope and be resilient and strong and survive? Certainly, if you're meeting with someone again, we also have a script for how you can bring this intentionally back up as the provider or in a long-term research interaction. There's some clinical notes and caveats here. You're welcome to go back and look at those, but I know that's not the focus of today. And just a reminder that this brief approach I just shared with you and this discussion guide has not been empirically evaluated. I'm only barely dipping my toe into doing that, but not with an RCT yet. And these are some of the great folks that have come together to help me develop this brief approach. And so with that, I'll stop. And I know I've asked a couple of different types of questions, but certainly would love to hear challenges you've experienced in doing this work too, in opening these conversations or assessing it with different research measures.